Okay, hi everyone. Thank you so much for joining us this evening or afternoon, depending on where you are. My name is Steph. I am the CES at Pittsburgh. So if you can, just a couple of housekeeping things, if you can put your name and your location, your full name and location in the chat, just so I can collect that in order to get full CE credit. And then we will email your certificates to you after as well. So full name and location. And we'll email that to you. This will be recorded, but the recording you will not get CE credit for. So just the live session tonight. Okay, so Dana is here. Dana is our CE, she is our doctor coordinator at Pittsburgh. She's been our doctor coordinator here for the ER department for 2 years. Before that, she worked at Human Hospital in the cardiac unit. So she was a cardiac technician for over 20 years. So she's had a lot of ECG experience, and she has 3 kids and 2 dogs and 2 cats. So I'm going to hand it over to her and we'll get started. And if you guys have any questions, you can put them in the chat and we'll be able to answer, everything at the end.
Okay. Get this up real quick. Share my screen. Oh, it's back.
It's back.
Okay. Can you see it? Yeah. Okay. Okay. So we're going to work through ECG interpretations. When you interpret ECGs, you kind of need to know all of the components of an ECG. So basically, you're going to want to think of your alphabet. For every normal heartbeat, you should always have a P, QRS, and a T wave. The P wave shows the atrial contraction, which is the little bump right there. Your PR interval goes from the beginning of your P wave to the start of your QRS wave. That represents the time taken to go from the sinoatrial node across to the atrium and then down to the ventricle muscle through the bundle of the His. Your QRS is your ventricular relaxation. And then your ST segment is this little flip right there. That also is ventricular relaxation. And then your T wave is your ventricular repluralization, which is right there. When placing your ECGs, your white lead is always going to be on the right side. So you're going to think the white is over the green, so snow over grass or snow falls on the grass. The black will be on the left. And then it goes over the red, so smoke over fire. And chocolate is close to your heart. If you do have a 5-lead ECG, you would put the brown one in the middle. When you're interpreting ECGs and assessing them, you're going to look at it and you're going to determine if the rhythm is regular or irregular. If it is irregular, is it regularly irregular or irregularly irregular? So regularly irregular would be an arrhythmia, an irregular heartbeat, kind of like a sinus arrhythmia. It is the problem with the rate of the rhythm, not the actual complex of the rhythm. And it's usually the rhythm or heartbeat is too fast or too slow. And here kind of shows you more of the waveform components, a closer look. where here you have your atrial contraction, which is your P wave. Your ventricular contraction is represented by your QRS wave or QRS complex, and your T wave is your repluralization. And that just again shows you more of your ECG segments, and kind of gives you an idea of how the electrical conduction goes through your heart. So for any normal ECG segment, your PR interval when you're measuring it should always be in between 0.12 and 0.20 seconds. So in your ECG strip, you're going to have larger blocks and then smaller blocks. Depending on the speed of your printing, is depending on how many blocks would be considered a minute, 3 minutes. But your PR interval should always be in between 3 to 5 squares. Your QRS complex is anything less than 0.12, and that would be less than 3 squares when you're measuring your QRS complex. Here are examples of a normal heartbeat, and in a regular heartbeat where you kind of see it just slows down a little bit right there. Some symptoms of an irregular heartbeat would be a fast heartbeat, slow heartbeat, fainting or syncope, breathing trouble, coughing, fatigue, dizziness, weakness, decreased ability to exercise or exercise intolerance. Here we have a couple examples of your more common irregular rhythms. There are other ones than these, but these are the ones that we see the majority of. You have a sinus arrhythmia, atrial fibrillation, AV block, VTAC, premature beats or VPCs, on-T phenomenon, pulseless electrical activity or PEA, ventricular fibrillation, and SVT. The sinus arrhythmia. So a sinus arrhythmia is basically a normal heart rhythm. It just slows down or speeds up, usually coinciding with a patient's breathing. So you'll see kind of whenever they're inhaling and exhaling, you have everything that should be there with your normal sinus rhythm, but the rate is just speeding up or slowing down. Here you can kind of see it speeding up a little bit, so it's getting closer together. Sinus arrhythmia is a normal finding in dogs, and it is abnormal in cats in the hospital, although it does appear more commonly with cats in home. So whenever you're thinking about the arrhythmias, you want to think, is this something life-threatening? Is this something that you need to stop, say, rounds or interrupt a doctor and pull them out of a patient room? Or is this something more that you can just tell them whenever they're finished with rounds, they're done talking to the client, or like kind of in passing? So with sinus arrhythmia, you're going to want to think, is this something that you should pull that doctor out immediately for and stop their rounds or stop their chat with the clients? So your answer for that one would be no, if the patient is otherwise stable. And then some common signs of sinus arrhythmia are irregular heartbeats. They become weak. They suddenly collapse or lose consciousness. They have abnormal breathing, abdominal swelling. They could be vomiting and also would have a decreased appetite. Our next abnormal heart rhythm is atrial fibrillation, or AFib. That is characterized by narrow upright QRS complexes, and it has an irregular ventricular rate. P waves are absent, during or in AFib. So you're not going to have a P wave in AFib in lead 2. So is this something that you would need to pull out the doctor and inform them that the patient is in atrial fibrillation? Yes. And then the treatment for AFib is usually medications. It's digoxin, diltiazem, atenolol, and amiodarone. Stuff's favorite.
Yeah, favorite word.
The A word. And then next irregular heart rhythm would be AV blocks. There are 3 different categories on AV blocks. AV blocks is a alteration in impulse conduction going through the AV node from the atria to the ventricles. You have a first degree AV block, a second degree AV block. There are several different forms of a second degree. You have a Mobitz type 1 or a Winky-Ball phenomenon. You have a Mobitz type 2 AV block or a high grade second degree AV block. And you would have a third degree AV block or complete heart block. Sorry, don't know why this is switched. Some of the signs of AFib could be, in mild cases, they really don't show any signs or symptoms at all. You would either listening or feel for an erratic heart rhythm very fast. They do have exercise intolerance, they coughing, lethargy, and loss of consciousness. Now back to the blocks. Here we see a first degree AV block. In a first degree AV block, your PR interval is going to be larger than 5 squares. So the only really true way to diagnose or to interpret a first degree AV block is to actually print it out and measure your PR interval, which is this little blip right there. Should you immediately inform your doctor or your vets about a first degree AV block? No. There's usually no treatment necessary for first degree AV block. If they are otherwise stable, you would just continue to monitor that. So there's no need to pull them out of rounds or pull them out of the client's room to inform them. You could just inform them in passing or when you're rounding the patient. Some common signs and symptoms of a first degree AV block. In most cases, patients will not show any signs or symptoms, but you could see a loss of appetite, vomiting, diarrhea. They would become weak, or in advanced cases, they would be syncopal or collapse and lose consciousness. So we have here a second degree AV block type 1 or a Winky block phenomenon. This is where your PR interval progressively gets longer in between your PR and your P wave and your QRS wave. It'll elongate. And then right before it drops a beat, your PR interval is going to be at the longest. And then it's back to the shortest. It's in measuring rates whenever your QRS is present again. And then again, if your patient is otherwise stable, you should not have to pull your doctor out of a treatment room to let them know. Because again, in most mild cases, there are no treatments required. In some severe cases, they would consider placing a permanent pacemaker. And then again, pretty much with all the blocks, you're going to have fainting, collapsing, or syncope, lethargy, exercise intolerance, or weakness. Your second degree type 2 AV block, you would have intermittent non-conductive P waves without progression, and then you're missing a QRS complex. You kind of have almost an extra random P wave here without a QRS complex after the P wave. Again, with a block, unless it is otherwise unstable, you should not have to pull the doctor out of talking to a client or rounds to inform them of this. There's typically no treatment necessary. You would continue to monitor the patient closely because the Mobitz type 2 in some severe cases could progress to a third degree or a complete heart block. So with the third degree, there's usually an underlying cause, or I'm sorry, the second degree, there's usually an underlying cause as to what's causing the block. So that's, if they are going to treat anything, you're going to want to treat the underlying cause of the heart block. And then again, in the most severe cases, it does require a permanent pacemaker. Signs and symptoms, again, you have weakness, exercise intolerance, sudden collapse, syncope, loss of appetite, and vomiting. And then with your second degree high, it's usually a 3-to-1, 4-to-1 is what it would be categorized at or considered. So a 3-to-1 high grade, you would have 3 P waves for every QRS complex that you have. And then here you can see where the errors are at. Each one of those are your P waves in between each QRS complex. So that would be a trigeminy. Then you would have, if you have 2 P waves, it's a bigeminy, so on and so forth. This, you're going to have an extremely low ventricular heart rate compared to your atrial heart rate. And then this one, you would want to let the doctor know, pull the doctor out of rounds and let them know that they are in a second degree high grade AV block. And then you have some medications here. Tributaline would be one, also pacemaker. Some common signs and symptoms of high grade or weakness, collapsing or syncopal episode, exercise intolerance, lethargy, fainting, loss of appetite, diarrhea or runny stools, and vomiting. Then we have a third degree AV block or complete heart block where your PR intervals or your P to P and your R to R intervals remain the same, but they don't talk to each other. They don't dance with each other. So you have your P waves here that march on through and are evenly spaced out. You have your QRS complexes that are evenly spaced out and march through, but they don't coordinate with each other and they don't talk together. So you have random P waves that aren't matching up with your QRS complexes. Usually your atrial rate is always going to be higher than your ventricular rate whenever you have a third degree heart block. And this most certainly is something that you need to immediately tell your doctor that your patient is in. And usually the only treatment for third degree heart block is a permanent pacemaker. Common signs and symptoms are a extremely low ventricular rate or heart rate. They're lethargic, have exercise intolerance, syncope, trouble breathing, and you can actually see their jugulars pulsating. Our next arrhythmia is VTAC or ventricular tachycardia. This is a condition when the ventricles beat very quickly. You have a non-sustained VTAC which is a VTAC that lasts less than 30 seconds and it is self-resolving. And or you have a sustained VTAC, which is a ventricular tachycardia that lasts longer than 30 seconds and does not stop on its own. VTAC can cause the heart to suddenly stop, which would throw the patient or put the patient into a sudden cardiac arrest. VTAC is definitely something that you want to inform your vet immediately that the patient is in. VTAC should be treated if the heart rate is greater than 200 and the arrhythmia is confirmed through an ECG. The main common treatments for VTAC are lidocaine, procainamide, sotalol, correcting the electrolyte abnormalities. And you want to try to keep the patient sedated and minimize their activity and movement as much as possible. Try to keep them as calm and sedated as you possibly can. With VTAC, you will see excessive panting, shortness of breath, fainting. They will be very weak. They could have seizures, and they will also have exercise intolerance. Our next is VPCs, or ventricular premature complexes. VPCs, if they are sustained or you have 3 or more VPCs in a row, that is what we would then consider a ventricular tachycardia. VPCs can be a single beat or they can be repeated, and they also can look different. You can have multifocal VPCs, whereas this one here is kind of inverted. Some you will go up. It just all kind of depends on where that electrical beat is being conducted through. And then if your patient is otherwise stable, you don't need to interrupt rounds or pull the doctor out of a room. If they are not stable, and if the VPCs become sustained and it goes into a ventricular tachycardia, then you would need to pull the doctor out and inform them that the patient is in VTAC at that point. But if they're just having occasional VPCs, you're going to want to monitor the rhythm. And again, you would have weakness, exercise intolerance. Your patients could be coughing. They could have cold limbs, have some labored breathing, and pale gums. Whenever the patient has a VPC and it is kind of thrown or you're seeing on the T wave, that is what we would consider an R on T phenomenon. And that R on T phenomenon is a superimposition of an entopic R wave on the T wave. It is usually likely to the ventricular arrhythmia. It can be associated with or without QT prolongation. And your R on T with corrective QT prolongation can lead to polymorphic ventricular tachycardia, which you see kind of up here. I'm sorry. Can you repeat that?
Does someone have a question?
Someone have a question? If you did, if you could type it into chat. Steph is monitoring the chat. But here, up here, you can see the polymorphic ventricular tachycardia, where it kind of looks almost like a wet noodle and all squiggly and not really uniform like regular, or not really, like ventricular tachycardia. And then, yes, this is certainly something that you want to inform your primary or vet about, or your doctor of vet about, because again, it can send the patient into a critical heart rhythm. And then amiodarone, electrical cardioversion, sotalol, and lidocaine, and quinidine are some of your more common treatments for the R-on-T phenomenon.
That's spring cabin trip. Third trip out there now. Don't look good.
I don't know if someone had a question.
We'll keep going. What are the differences between polymorphic VTAC and VFib?
They pretty much look this. So polymorphic VTAC and VFib, which we will get into VFib shortly here, but they're almost looking the same. Pulse deficits, basically you're not really going to feel the pulses correctly as you should. They're not going to be strong, normal pulses. They're going to feel irregular. Electrical cardioversion is where you actually shock the patient into a normal heart rhythm. It's not seen in animal world as much as it was in the human. A lot of, in human medicine, VTAC, our first, we would cardiovert them and shock them. That was more so in the cardiac specialty, is where you would see the electrical cardioversion, but that is actually where you get the paddles and the gel and you shock the patient back to a normal heart rhythm.
Pulse deficits when the heart doesn't, when
Yes.
the pulse doesn't match up with the heart.
So yes, to answer your question, yes, it's whenever you would not match up to what you're hearing. Ventricular fibrillation, or VFib, is a life-threatening irregular heart rhythm. During VFib, the lower chambers of the heart are not contracting properly in their very rapid, uncoordinated manner. This is the most common deadly arrhythmia. This is definitely something that you would want to pull the doctor out and let them know that the patient is in. In mild cases, sometimes it may not require intervention. Moderate to severe cases would be treated with medications, lidocaine, defib, or defibrillation, because they are more than likely arresting, and at this point you are already doing CPR. Common signs of VFib are sudden weakness or trouble rising. Their limbs are very cold because you're not getting proper circulation. The gums are pale. They have labored breathing, worsening of their exercise intolerance, and decreased appetite. So like I said, it's more than likely at this point, if they are in a ventricular fibrillation, your patient is more than likely arresting already, and you're already doing CPR. But if they're not and they're going into it, then you're going to see a very sudden, a very sudden decrease in their alertness and their exercise intolerance, and you're going to want to get ready to shock them or do the electrical cardioversion. Next, we are going to talk about pulseless electrical activity, or PEA. No. Oh, can you hear me now?
There.
Okay. It just popped up that it was muted.
That was weird.
Yeah. So in PEA, your patient is already dead, but you still have an electrical impulse running through their body. So you're still going to see some sort of complexes on your ECG. It could be normal sinus, it could be V-fib, it could be a random escape beat. You're going to see something on there, but your patient is already dead. You're not going to be breathing. You're not going to be moving, have pulses, anything like that. So you're already going to be doing CPR at this point. Yes, you're going to be screaming code. Like I said, the patient is already dead. So this is definitely something that you want to inform the vet that the patient is in. Again, you're already going to be doing CPR because you're not going to have anything but some random escaped electrical activity on the ECG. Our other treatments for PEA are epinephrine, vasopressin, and the first round of CPR, you can use atropine. Again, you're not going to have any heart sounds. You're not going to have any pulses. Your patient will not be breathing, and you will not have any cardiac output. Your patient is going to be dead, and you're just going to have some random electrical activity showing up on the ECG. So it is definitely something we are going to be screaming code, starting CPR, the works. And then we have supraventricular tachycardia, or SVT. This is arrhythmia where the heart beats faster than normal. The QRS complex is regular and narrow, and your P waves are there, but a lot of times they are inverted, which would mean the blip would be going down and not up. Or a lot of times you're not going to be able to see them the greatest because the QRS in the heart is beating so fast that they're there, but they're kind of hidden within your QRS complex, P wave, T wave. So they are right there, and I know it's kind of hard to see, but they are right there at that little blip, but it is upside down or inverted. This is definitely something that you want to inform your vet that the patient is in, because most likely in dogs, your heart rate is going to be above 160, and in cats, your heart rate is going to be above 240. Lidocaine, sotalol, diltiazem, and or an ablation are the common treatments for SVT. An ablation is done based under the cardiac specialty, but that is basically where they would go in, usually done under an echocardiogram with like a little laser or something, and they actually kind of kill off, or they would like hit that area that they believe is causing the irregular heart rhythm. It causes the irregular heart rhythm. That is a good question. We will get back to you on that. There are different things that could be causing SVT. But SVT requires the atrial and the atrioventricular junctional tissue for its for the inability and the maintenance. Sinus tachycardia originates in the same area, but in the majority of cases, sinus tachycardia is temporary and is usually a response to an external stimuli, whereas the SVT and the supraventricular tachycardia are not. Here we have some common signs and symptoms of supraventricular tachycardia, or the SVT, that you have a very rapid heart rate. The patient is panting, has shortness of breath, they are weak. You will have a syncopal episode, or they kind of lose consciousness. You can have some coughing. And their breathing is usually abnormal where it's open mouth, rapid, or labored. All right. Now here in the chat, we are going to have name that rhythm. So I want you to take a look and in the chat on your best guess, if you could see what you think this heart rhythm would be. And then, sorry, I was looking up too. So for your question on the
normal rhythm, abnormal
on
signs,
new,
tachycardia.
for your question on the SVT in dogs, usually it's caused by heart disease. It's caused by some electrical or electrolyte imbalances. Some dogs are just predisposed to it or just develops for unknown reasons. So here, if we want to kind of look at this, we're going to look, do we see a P wave for every QRS? And over here, do we see a P wave for every QRS? No. So then we would know that that would not be normal sinus rhythm. And then your QRS complexes here, they look pretty similar, regular, they're spaced out normally. So then that would kind of eliminate your AFib. Let's see if I can do it. Did anyone get the
No. But science tachycardia. Okay. You said there's no P wave. Someone said VPC.
No.
So no P wave.
No, a VPT.
SVT.
Yep, SVT. There you go, Katie. That is correct. This is a
Winner, chicken dinner.
This is an example of a supraventricular tachycardia. So you have, put back here, you have a very, very fast rhythm. Your QRS complexes are narrow and you cannot see your P waves. Right. Here we have another one.
Someone said VFib.
Correct. Correct.
Yes.
Correct. That is a VFib. VFib is where you have the wide QRS complexes, but it almost looks like a wet noodle. It's all squiggly here and there, whereas we'll show you more. And when you have a VTAC, it's more of a uniformed looking complex. All right. And this one. So this one here, do we have P waves for every QRS complex? And do they look like they're evenly spaced? Meaning, are they 3 to 5?
Second degree AV block.
Close. It is a block, but it's not second degree. It is a block. Correct, Lucas. It is a first degree AV block. First degree, again, very hard to tell.
When it's,
First degree are very hard to tell, kind of just looking at them on your heart monitors. A lot of times you would have to print out a monitor strip to be able to tell or to properly assess, because at first degree AV block, your PR interval right here is going to be longer than the 0.20. So longer than the 5 blocks. All right. Here, again, first thing you're going to want to always look at and assess is, do you have a P wave for every QRS wave? For R on T, you're just going to have usually one random beat, whereas V fib, R on T kind of can lead into, well, into it or torsades. But R on T, you're just going to have that one random VPC that's firing on the T wave. Whereas V fib, it looks like a constant wet noodle. R on T is just basically a one single beat that throws it into a deadly heart rhythm. So here we're going to look, do we have a P wave for every QRS? Do they look evenly spaced out? All right. Yes and yes. Correct. Correct. This is an example of normal sinus. All right. So here, this one looks a little funky. Here you're going to want to mainly look at lead 2, which is going to be your middle ECG. Because anytime you're interpreting, you're always going to want to use lead 2. So in lead 2, almost close. In lead 2 here, we have your P waves. But do we have one P wave for every QRS complex that we have? Or do we have multiple P waves?
There's a third degree.
No.
Second degree type 2.
High grade, correct. Second degree type 2. Oh no, that one is, oh, sorry.
That one's
That one is third degree.
That
Yeah.
is third degree.
That is third degree. So you have your PR or your P waves that march consistently. And then you have your QRS complexes that march consistently. And then you have them in between, but they are evenly spaced out, but they don't dance together. So you don't have your PR interval or your PR rate, or R to R is the same as your T to T or your rate. So your QRS complex rate and your atrium rate are consistent. They're the same, they're regular, but they're not talking together. All right. So on this one can be a little bit tricky too, because so for every P wave, again, do we have a QRS complex? There's something that looks different in this strip. What looks different in this strip?
VPCs.
Correct.
Yay.
Correct. You have your VPCs, or ventricular premature contractions. And then these ones on this rhythm strip shows a single, like monomorphic. You also could have polymorphic VPCs, where this VPC, the QRS complex, is up. The next one, it could be down. Like again, it all depends on the electrical conduction. So your VPCs could look different on.
Someone wrote every P wave has a QRS, but not every QRS has a P wave.
You don't.
Or is there a P wave still?
I don't believe there is a P wave still because you're contracting before. So you might, but it's going to look different. I gave some of them here. If you can kind of see right here, the P wave is almost inverted on this one. I don't know if you can see.
Yeah,
Yeah, it's kind of like a T wave. You will have a P wave, but it's going to look different than your normal P wave. Whereas if here, it almost looks like your T wave because it's inverted. So you would have one, but your QRS looks different and it's not spaced out properly. So you're going to have a P wave, you're going to have a QRS wave, but your QRS is going to look different because it's going to come faster. It's not going to be spaced out regularly.
So wide and bizarre.
Yep, wide and bizarre and funky looking. All right, so here, doesn't look like we have any P waves on this one. So if we do not have
VFib, VTAC.
VTAC, this is VTAC. VTAC is going to look more regularly irregular, whereas kind of line up more evenly. Your ventricles, it's not fibrillating. So on VFib, your ventricles are fibrillating and it's going very fast. So that's why you have the wet noodle looking QRS complexes. Whereas with VTAC, your ventricles are just going super fast. So it's not fibrillating. So you have more of a QRS complex. It's going to be very wide looking, but you're going to have almost a regular because it's beating almost properly, but just fast. Whereas when you have VFib, your ventricles are fibrillating and they're just kind of just going real crazy. And you have your QRS complexes that just look like a wet noodle.
Okay. That one's a hard one.
They're very hard to tell apart. And your VFib also looks a lot like the Torsades de Ponts.
Yes.
They are very, very similar looking rhythms. But that one you have VTAC, where you have more regularly, your QRS complexes are very wide looking, but they're pretty evenly spaced out and your QRS complexes look very similar. So on this rhythm strip, do we have a P wave? Did you just like give me the grade? Huh? Is it because it like did a grade for me over there?
No.
Okay, good.
So
So the
sinus arrhythmia, first degree. Sinus arrhythmia.
so on this one, do you have a P wave for every QRS complex that you have?
Yes.
Yes. Do you do your PR intervals look the same? Do your PRs here look the same? It is a regular, irregular heart rhythm because you have complexes that have a PQRS. But on this one, we're missing something right here.
Right where?
My error went away.
There you go.
There we go. Okay.
Okay.
So on this one, we are missing something kind of right here. And this is kind of hard too because it is probably the T wave is probably hidden in your T wave here because you're missing here. So right here, we're missing a beat. We're missing, this one's kind of hard. So on this one, the P wave is probably hidden If you look close, how the T wave almost looks double tinted. Like this here,
Like the
T
little
wave
bump
is
in the
normal.
T-wave.
This T wave here has an extra little bump in it. That extra little bump is your, it is not RMT. The
So
extra little bump is your P wave, but you're missing something.
So it's a bradyarrhythmia.
That's a block.
It's a block.
It is a
Just-
block.
We're looking at the rate. It's slower.
Correct. And something is being dropped right here. Because you do have a P wave here, it's just hidden inside your T wave. Because if you look and see how this T wave looks like a tenth, and then this one has the extra little blip, this one here has an extra little blip. So your P waves are hidden right here inside your T wave, but you're missing right here. What are you missing?
Someone said
Correct.
it's type 1,
Type 2.
type 2.
Correct. It is a second degree AV block type 2 where you have
That one's hard.
that. This one is hard because your P waves are hidden in your T wave. But you have you have a PR interval that does march through, but right here you're missing something, and then you're completely missing a QRS wave. So your PR intervals stay the same. It doesn't elongate like it does in the AV block type 1. Your PR intervals stay the same. You're just going to be missing a random QRS complex.
And for the people that because RMT, if it was RMT, it would be tachyarrhythmia.
Yes.
So,
It would be fast. It would not be.
and then
it's
someone
slow.
asked, based on the size of the strip, how can you tell it's regularly irregular?
A regularly irregular heartbeat is a heart rhythm that you have right here. We have a regular heart rhythm where you have your P wave, your QRS, but then you have abnormality or irregularity. So with this strip, with these ones, it's hard to tell. You're obviously going to use a longer strip when you're interpreting. It's just on this slide. You kind of have to shrink them down. But with an irregular, or with a regularly irregular, you have every beat has a P wave, every beat has a QRS complex. Your R to Rs and your T to Ts are regular most of the time. It's just sometimes like an sinus arrhythmia where it's going to be spaced out. So you have your normal sinus complexes, the rate is changing, not the complex.
So where that little blip is, where the T and the P meet, that it would be a P wave by itself.
Correct.
Okay.
If it
So
was
that needed a QRS complex. with
Correct.
it.
correct, it should have been a little bit spaced over more.
Okay.
So your P wave here should have been more over here, and it was missing your QRS complex. And again, I used this one because it was harder to tell where your P wave is. Even these little tiny blips, right there, if they march through, and you can see that consistently in all of your T waves, in all of your P waves or anything like that, that's where your P wave is at, or that's not just artifact. Because sometimes too, with animals, you can have artifact, your ECG leads aren't always getting the best contact. So that's the one going to be your first thing. If you notice an irregular heart rhythm or rate, you're going to want to check your leads and make sure you're getting good contact.
And then because it has
And then-
those other P waves that don't have the bumps on it, that is like a clue too.
Correct. Here, and then here you have your other P waves here with your QR. So you have a regular complex right here. And then right here, hidden, is your P wave, but you're missing
The QRS.
your QRS. All right, this one is going to be tricky because this is one of the ones that you could see many forms. Correct. Winner, correct. This is a form of PEA. Kind of gives it a throwaway is that here your P waves just are not firing at any regularity. Your QRSs are there. But on this one, the only way to diagnose PEA is to check the patient and assess the patient, because here it looks funky because your P waves are not lining up with your QRSs, and it looks like there's something going on and your patient is not breathing. So obviously that is.
So that could like look like a block, but then looking at the big picture, if your patient looks like it's dead
Correct.
or dying.
Correct. Because on this one, if you wouldn't look at the patient and you would just see this rhythm strip, to me, that looks almost like a 3rd-degree heart block. Because your P waves could be, you could have a hidden P wave here. Looks like there could be one possibly here. This little blip could be an attempt of a P wave. This looks like it could be a 3rd-degree heart block. Your QRS complexes look evenly spaced out and look like they're marching through, but your patient is not breathing. Your patient does not have pulses. So this one, the only way to diagnose PEA is to look at the patient and assess the patient. Because again, your heart rhythm could look like this. It could look like VTAC. It could look like VFib. It could look like torsades. Key, the patient is dead. You're going to be doing CPR at this point. And the next one. On this one, do we have a P wave for every QRS complex? Are they evenly spaced out? So we do have a P wave for every QRS complex. But they're not.
Sinus arrhythmia.
Correct. This is sinus arrhythmia. More than likely, it's sinus arrhythmia. If you watch the rate, 99% of the time when they're in a sinus arrhythmia will coincide with the patient's breathing. It's going to speed up and slow down with their breathing.
I don't know. Where did it go?
Pause.
Was it, which one did you use from?
Pause for a minute. Sorry, technical difficulties. I will continue to share my screen. We were missing a
Do you have
slide.
another one after that?
Yeah.
You just want to go with that one.
Even though they kind of.
Yeah, it's fine. Put it in. I don't know where our pictures are.
So let's go back. Sorry, I don't know what happened to our picture for that one. It disappeared on us. We literally just spent the past hour beforehand. Oh wait, now it's here.
It's there? Okay. Well, you can always explain.
Okay. Sorry. So this one here is where you have your R on T. Here you can kind of see how it's a very fast heart rhythm. It's going to look, exactly, technology. It's going to look different than your VPCs. You're usually going to have your R on T, and then you have another very fast complex right afterwards. So VPCs, you're going to have a longer space in between, where on this one here, the R is firing on the T in your next QRS complex. With the R and T, they're going to be very close together because you're going to be in a tackier rhythm than just a VPC. VPCs are not always, but usually on a slower heart rhythm.
Instead of skipping a beat, we skipped a slide. Yes.
Yes.
I like to look at the M. Like, it looks like an M.
Yes, it looks like an M here. Whenever you have your R on T, you kind of see it looks like someone just wrote an M. moving on. So for this one, we have a P wave for every QRS. There's something changing. What is changing in this heart rhythm?
Second degree AV block.
Which type? Correct. Your PR interval is changing. What type of second degree AV block?
1.
Yes, correct. Type 1. On second degree type 1, your PR interval, see how the line from your start of your P wave to the start of your QRS is getting longer. And then you were missing right here because you have your T wave. Here's your next P wave. And then you're missing your QRS complex. And then here, it goes back to your PR interval will be the shortest again. And then it continues to get longer and you drop your QRS. So that was second degree AV block type 1. And then these are just where we got everything. Does anyone have any questions?
Do you have any like tips for like when you get into the different types, like to help?
The block.
Yeah.
The
like,
blocks are hard. The blocks, I'm even still doing ECGs for 20 years. There's times where even in the human world, we didn't see second degree type 2 very often. So there were times where you had to look them up and what is this? Blocks are hard. Complete heart block is obviously going to be the easiest.
Yeah.
Because you're going to have your PR intervals are going to stay the same. Your R or your T to T intervals are going to stay the same, but they're just not going to mix. First degree block is also going to be another easy one. Once you get a hang of looking at rhythm strips, you're just going to be able to tell by looking at it that your PR interval is different, longer. Your type 1, you're missing your PR interval is again going to get larger.
Okay.
And then it's going to
then it
drop.
drops.
Yeah, your type 2, you're just going to be missing a random beat.
Okay.
Yeah,
that's helpful.
But I know they have some different videos online that people have come up with songs to help learn.
Yeah, there's a poem and stuff. I've seen that too. I don't know if anyone has any other questions. And we'll go back to the chat. I just want to make sure we don't miss anything. I think we caught all the questions that were in there. But please, yes, put your name and location in the chat to get CE credit, and we will send out those certificates to you as soon as I get them out to you. So give me a couple days and we'll get them out to you.
If you think of any questions, you can always find me on here. Email me, email Steph, and she can forward it to me, and we can find some answers for you.
Yeah. And thank you guys so much for spending your evening with us. We really appreciate it. And hope you guys learned some stuff about ECGs. I know they're hard. It's always learning them.
Even after this many years, I still question myself at times. So don't feel bad if you don't know. I've been doing them many years, and again, I question myself. So they are very complicated.
All right. Well, I hope everyone has a great